So, good morning, good afternoon, and good evening, everyone. Thank you for joining us for our August of 2021 Global One Health Initiative webinar supported by the NIH Poverty International Center. Today, we will be hearing from our special visiting guest, Dr. Samuel Kariuki, who currently serves as the Director General for the Kenya Medical Research Institute. Oh, I apologize. The title of Dr. Kariuki's talk today is One Health AMR Surveillance Implementation in Low Middle Income Country Settings, Kenya, a Case Study. So we ask that you hold questions for after Dr. Kariuki's presentation and then submit them through the Q&A box. And then I'd like to go ahead and briefly introduce Dr. Kariuki. Professor Sam Kariuki obtained his DVM and Master's in Science from the University of Nairobi in Kenya and his PhD from the Liverpool School of Tropical Medicine in the United Kingdom. He currently serves as Chief Research Officer, Substantive Director of Research and Development, and Acting Director General at the Kenya Medical Research Institute. Dr. Kariuki is also a Fellow of the American Academy of Sciences, honorary faculty member at both The Ohio State University and the Wellcome Sanger Institute, visiting professor of tropical microbiology at the University of Oxford, and a member of the American Society for Microbiology. And he further serves as a member of the World Health Organization Strategic and Technical Advisory Group for Antimicrobial Resistance, and was previously a member of the advisory group for the integrated surveillance of antimicrobial resistance. His research interests are in the epidemiology and genomics of enteric bacterial pathogens and antimicrobial resistance, and he has authored 157 papers in peer-reviewed journals and 3 textbooks on antimicrobial resistance and food safety. He led the initiative to develop a situation analysis, which led to the Kenya National Action Plan to combat and control antimicrobial resistance, now serving as a member of the National Antimicrobial Stewardship Committee, overseeing the implementation of the National Action Plan in Kenya. And with that, I will hand it over to you, Dr. Kariuki. I will go ahead and get your PowerPoints up here.
Thank you very much, Laura, for that very kind introduction. And good morning, good evening, colleagues, friends. I'm very, very pleased to be
Sorry.
Yeah, I've already asked Laura to allow me to unmask because everybody else will be masked here. So that I'm a bit more loadable, so that everybody else can hear me properly. I'm fully vaccinated, fortunately. Hopefully things will be okay. So what I thought about today's presentation is that apart from the kind of research that I'm basically involved in, I would also present some background information regarding KEMRI and the mandates, scientific research themes at KEMRI, so that anyone else who may feel they wish to probably collaborate with colleagues at KEMRI will be able to have an opportunity to know what goes on at KEMRI. My main area of research is antimicrobial resistance. In the last 2 years, been involved in building capacity for surveillance of AMR. And we think we have a story to tell, especially for other African countries wishing to implement these kind of studies. So this is a pictorial representation of KEMRI. Its headquarters is within Nairobi, part of a huge institution comprising of 12 different centers. And this would be the equivalent of departments at the university level. And KEMRI was established in 1979. It's a fairly young research institution. under what we call the Science, Technology, and Innovations Act. Early this year in March, we received a new legal notice, which then provides KEMRI with additional mandates, and especially in public health. I'll briefly go through the mandates here. As you can see, we have a total of 6 substantive mandates, and then the 7th one is such that the Ministry of Health, to which we are affiliated, would give us additional research mandates for the sake of responding to public health. So we conduct health research, biomedical and public health research for human health. And we also involved in research building capacity for human health. We have actually a postgraduate school, and we operate this in conjunction and in collaboration with another university within Kenya, that's Jomo Kenyatta University. And we are also mandated to collaborate and partner with other local and international organizations to carry out human health research and capacity building. Previously, we did have this mandate for capacity building in terms of providing degrees, but now we have been mandated by law to be able to provide, to be able to be accredited as a research capacity building university. We advise the Ministry of Health on health research policies and priorities. And most important this year, we've been asked to take leadership in scientific and technological innovations, and especially in issues to do with diagnostics, surveillance, and treatment options that could be innovative in terms of evolving public health threats. And we have also been mandated this year to establish an incubation center where innovations could then be translated to products. So those are our mandates. And then for these mandates to be carried out, we have 6 research programs. And the 7th one, which was added this year, is what we call One Health. It's very new, but we're hoping that we'll be able to establish that as well. And you can look through the research programs, infectious and parasitic diseases, and there are various examples of what we do under that program. Non-communicable diseases is a major thematic area for research. Sexual, reproductive, adolescent, and child health, another important area for public health for the Ministry of Health as well. And then we engaged in public health and health systems research because of the evolving nature of healthcare systems in Africa. We constantly have to research on sustainable health systems, financing, and how that relates and translates to being able to respond to emerging public health needs. Biotechnology is an important aspect of what we do as a program. Basically, we try mainly to come up with new diagnostic methods or new diagnostic tools, vaccines, and we take leadership in working with others, collaborators, and especially in clinical trials for new products, either vaccines or therapeutic products. We have a huge program on natural products research and drug development. And here we're looking at candidates and prototypes that could be developed under innovation into products for either diagnostics or treatment or prevention of these things. So for anyone wanting to look at some of the areas that they could work with, KEMRI, these are the 6 main programs. The 7th one is One Health, which is being established, and that is going to cut across many sectors, looking at different ecosystems, human health, animal health, and the environment. And these different centers are spread across the country, and we have new centers up north, very close to Ethiopia, in a place called Mandera, where we've been supporting COVID-19 surveillance for that region. And the rest of the centers are actually spread out dependent upon the prevailing circumstances for endemic disease in the regions. So that's a short background about KEMRI. But now on to what really we do as a team in terms of antimicrobial resistance surveillance. I started off in the Department of Microbiology, where I was head of department for 6 years before getting to lead the Institute Research and Development portfolio. And my outline of this particular study and presentation will be on AMR, some of the work we've been doing on surveillance, and particularly where I'm involved as a national antimicrobial stewardship committee member is in the National Action Plan implementation. And we'll conclude on looking at what challenges and gaps exist. And some of these really cut across the African region in terms of the challenges that we face implementing the National Action Plan on antimicrobial resistance. Just to bring this into context, most of us will be aware about this, that antimicrobial resistance, as we abbreviate as AMR, is increasingly a very, very serious global threat to public health. Right now, we see, even with COVID-19, we're seeing a lot of comorbidities due to antimicrobial resistant microorganisms and infections. Untreatable infections, prolonged hospital care, and most of these effects happen within the low and middle income countries because we have very few other options. When the first line of treatment fails, we have very few other second line or third line options for treatment. And so therefore, over time, we've really are desperate of new antibiotic treatment options that could be available. Yet in industry, we have very few new molecules that are being developed for purposes of addressing AMR. The economic burden is quite huge with regard to AMR, as we know. These being really reflected on food security issues, direct impact on public health because of the cost involved. And we estimate, especially in low and middle income countries, a lot of this is going to bring a huge, huge cost to the economies of growing countries. Fortunately, through the Global Action Plan and the involvement of the tripartite organizations, GOHi, FAO, and WHO, there is a lot of political, professional, and public health awareness that is driving how we be able to react to addressing AMR. But back home in Kenya, we really, up to about 3 years ago, we didn't have a systematic national surveillance program in place, but now we do, and we're glad that this is moving along very well. There's a lot of government interest and support by the Ministry of Health to be able to have this fully implemented. And we count ourselves very, very lucky that the Ministry of Health has come on board to be able to see AMR as a major public health threat in the country. One of the major challenges is in terms of data that we have. We know that, for example, a lot of farmers use antimicrobials for prevention of disease, for prophylaxis, but we don't know how much of that goes into animals and how much that effect has on antimicrobial resistance. In some settings, we find there is overuse of antibiotics, and especially in low income settings, in informal settlements where people go and buy antibiotics over the counter because they do not wish to bear the cost of visiting hospitals, because we have a challenge, especially in our countries, where we do not have comprehensive medical insurance covers. So everybody is trying to cut around corners to be able to get treatment for their children or themselves by buying drugs over the counter. What I want to do is take you through a couple of slides that will provide an overview of some of the areas of concern that my team has been involved in terms of surveillance. And for the last 15 years, been working in one of the informal settlements, about 20 kilometers east of Nairobi. And in this informal settlement, population of around 150,000. Conditions are very, very rife for purposes of very rapid transmission, and especially of enteric infections. And so antimicrobial resistant organisms are able to emerge because of the kind of situation that this population lives, but also because of the availability of antibiotics, which most of the time are misused or abused. And these are the three villages where we've been doing some work on the surveillance of AMR, and also looking at some of the very, very important public health diseases of importance, and especially cholera, non-typhoid salmonella, typhoid itself, and E. coli diarrhea, and especially in children below 5 years of age. Very, very highly populated area with sometimes poor infrastructure in terms of roads. Water supply is not very reliable, and even treatment and disposal of sewage is also a challenge. And we'll begin with cholera, and just as a background, Kenya, especially in the northern part, is host to nearly 500,000 refugees from neighboring countries, especially Somalia. And in early 2012, we started observing strains of cholera that were resistant to third generation cephalosporins. And this was very concerning for us. It was the very, very first time that we found cholera that was not responding to first line treatments. And this outbreak then spread out to other areas of the country, obviously because of interaction between the refugee population and the rest of the country. And when we analyzed these strains, they were very, very similar in terms of genomic relatedness to strains that were causing the major epidemic in Yemen at that time. And when this case was first brought to my attention, I became a bit hesitant. But then, on further investigation, actually, we found that these were actually extended spectrum beta-lactamase producing Vibrio cholera. And since then, this has been spreading across the country and exchanging mobile genetic elements with other enteric pathogens, especially E. coli and Klebsiella. What we found is that the plasmid in this organism, which measures approximately 169 kilobase in size, contains three main regions, and you can see there. And these three main regions carry numerous genomic repertoires of antimicrobial resistance. And this is very, very concerning because this is the very, very first time that we were able to show this in Vibrio cholera, which before that was responding very well to most of the commonly available antibiotics. And this is something that we're also finding in Klebsiella pneumonia. We find the same large mobile genetic element in E. coli. So there's a lot of exchange of these plasmids across the whole spectrum. As a result of the work we've been doing on cholera, currently we have an ongoing joint program on research with colleagues from Emory and with colleagues from Ohio State University. And this team is now looking at how we can be able to accelerate prevention, preparedness, and control of cholera through hotspot mapping, genotyping, assessing exposure, and of course, improving water, sanitation and hygiene, and being able to introduce the WHO-approved oral cholera vaccines for purposes of prevention. And this is a project now that is entered into its second year. And the main research question here is, what are the critical intervention pathways that could have the most significant public health impact in terms of controlling cholera? And we're using Kenya as a case study, but this is something that can be applicable to other institutions and other endemic areas of similar nature in the African region. And we're doing, we're mapping hotspots of cholera, especially in the informal settlements. We know where these are likely to arise from. We know for now, at least some of the exposure pathways that have the highest risk, and being able to assess those through routine molecular characterization and assessment through epidemiological surveillance. And we're utilizing a tool that has been developed by our colleagues from Emory University. We call it the SaniPath tool, to be able to grade the various exposure pathways that are very, very critical to ensuring that we are able to intervene in the most appropriate way, in the most effective way, for purposes of being able to interrupt transmission of vibrio cholera. And we're utilizing both technologies of very basic microbiology approaches, but also GIS and whole genome sequencing to be able to know exactly what are the genotypes in existence and how are these transmitted across the various pathways from humans to environment and back to humans again. And we will have pilot intervention tests and projects across the intervention phase in this region. As I said, this is happening in a population of about 150,000. And we're working very closely with the Ministry of Health because they are very, very interested in this intervention to know that they can be able to translate this to the refugee camps. They can translate this to other rural areas where cholera may sporadically be a very, very important disease. So this is the workflow in terms of what we'll be doing. We've been able to do assessment of 14 different pathways that we thought were most crucial in transmission, not just of cholera, but also of other enteric pathogens that are food or waterborne. And as I say, this is something that we can apply to other waterborne and other foodborne infections in the region. And we'll be able to analyze the different pathways, and within each pathway, take about 20 samples to be able to obtain clearly what pathogens are involved, what genetic markers can be used for purposes of tracking these infections, and at the same time, be able to assess antimicrobial resistance in terms of transmission between different pathways. And then on to another very, very important pathogen. And this is one of the pathogens we've been working with colleagues from here in Ohio State University, my colleague Wanderson and other team members on antimicrobial resistance or multi-drug resistant non-typhoid strains that affect especially children below 5 years of age. And one of the huge challenges, of course, with the informal settlements is that we have huge populations moving from rural areas coming to the urban areas looking for jobs, and then they have no accommodation. And then they look for the cheapest ways to be able to survive in the city by encroaching on areas where we have no government land that's not occupied, and then challenge with sewer systems, a challenge with water supplies. And one of the diseases that is a big challenge in these settings is multi-drug resistant Salmonella typhimurium, sequence type 313, and Salmonella enteritis. sequence type 11. Those are the most important sequence types that cause this very, very invasive disease. And this is one of the settings where we do our studies. These are an outpatient clinic in the informal settlements where we see children below 16 years of age coming in with fever of at least 3 days or so, with or without diarrhea. And then we have age-matched controls for purposes of understanding the epidemiology of this disease. And this is the age distribution of the patients we have been understanding in the last 5 years. Again, all of them below 16 years of age, but most important for purposes of NTS bacteremia is children below 5 years of age, or 16 months. And back to a bit of background regarding invasive non-typhoid salmonella. It's a major cause of morbidity and mortality in children below 5 years of age. And you can see the incidence rates are quite high, and they are variable, actually, dependent on where you do the studies. Well, we have very, very high incidence rates, especially in informal settlements, and then much lower when you go to the rural areas. And you can see the untreated cases of NTS bacteremia, extremely high mortality rates. Up to a third of these children may die within 48 hours. So far, although we have not identified any zoonotic source, despite trying to understand the possible transmission between livestock and humans, this is a disease we think is mimicking salmonella typhi in terms of being human adapted and in terms of transmission from human to human sources. And this is salmonella typhimurium, sequence type 313. We have three main lineages and one minor one. We have sequence type 19, which is quite common in many other countries and elsewhere globally. But sequence type 313, which has two main lineages, is the most common, actually currently contributing close to 80% of all infections of invasive salmonella typhimurium. Now, when you look at these lineages, they are very, very closely related, as you can see from these dendrogram drawings of phylogenetic relatedness of the various strains. Again, if you look at antimicrobial resistance, again, most of these are drug resistant. Now, one of the most intriguing findings from our studies here is the fact that you find children who are apparently healthy, but yet they are carrying the very same strains that are causing severe disease in other children. In other words, we have a high carriage rate of very virulent strains that would otherwise cause disease in vulnerable children. So we're looking at children who are apparently healthy as possible risk hazards, especially in homes where you find vulnerable populations of children. And these are the children, or these are the homes we want to target for possible vaccine introduction for prevention purposes. And you find the same kind of patterns with regard to salmonella and enteritidis. Again, we have four main lineages of importance. We have another one that we labeled Kenyan lineage that deviates completely from the other lineages that we have. And then the others, the global epidemic lineage is found in many other countries where salmonella enteritidis is a big disease. And we have a Central East African lineage that has been studied in Tanzania. We have cases that have been reported in Mozambique, in South Africa. Again, in terms of antimicrobial resistance, you find across the board between cases and controls, there is a lot of carriage of these particular strains that are virulent in normal populations. In other words, as these organisms tend to become more human adapted, we tend to have a higher carriage rate in the human population. And this is concerning in terms of the evolution of these epidemics. But at the same time, it tells us that when we introduce vaccines, it's possible that we'll be able to intervene and be able to reduce the burden of carriage for those reservoirs that we find in the general population. So again, this is just sort of to emphasize the four main lineages that we're dealing with, sequence type 313 being the major one as far as Salmonella typhimurium is concerned. And this evolution from predominantly livestock associated or livestock or zoonotic associated lineages has been happening over the last 75 years. We've had this evolution towards the more human adapted strain types and lineages over that period of time. And the same with some of the entities, we find that when you do your phylogenetic analysis and track this down, the evolution history, this evolution has happened over the last 50 years. Again, with strains acquiring more virulence, but less determination in terms of reservoirs in livestock, more human adapted for that matter. When we follow up these populations, and especially the young children with NTS and typhoid, invasive bacterial disease, you find that they tend to coalesce around the same villages, which means that we have epicenters of these outbreaks in various villages. Probably begins in one home and then spreads outwards. And you can be able to tell that wherever you find a case of typhoid, you're able to find around the same village a lot of other cases of NTS bacteria. Again, we tend to think that there's a lot of microevolution and microtransmission within households and within villages in these highly densely populated endemic areas. Now, some of the emerging research questions with regard to NTS is about duration of carriage. We really want to understand how long does carriage in apparently healthy children take. And during this period, is there a change in genotypes? Is shedding of NTS attributed to antimicrobial resistance? In other words, are the more multi-drug resistant strains able to probably be transmitted much more rapidly compared to those that are fully sensitive to antimicrobials? Are we able to track both the bacteria and AMR genes in the environment through, for example, through the ecosystem interaction between humans and the environment, and vice versa? And can we be able to then monitor certain areas for possible intervention? And this, of course, is linked to our possible use and introduction of a vaccine for purposes of control and prevention of NTS. And lastly, resistance phenotypes associated with patterns of use of antimicrobials in the endemic areas. We know for sure there is a lot of antibiotic use and misuse in these settings, and with this be related then to the emerging patterns of AMR. So in the remaining minutes, allow me also to discuss briefly about one other area of enteric pathogens that is of significance to our region, and that is typhoid fever. Typhoid fever is an old disease controlled in many other regions of the world, but still endemic in our settings because of poor wash conditions and infrastructure. Of concern here, of course, is the emergence of fluoroquinolone resistance, where we know fluoroquinolones are the drug of choice for treatment of severe and multi-drug resistant typhoid. And this is a study that we did with colleagues from the Sanger Institute in Cambridge, where we looked at a global collection of 1,800 isolates from a total of 63 countries across 6 different continents. And basically what you find in Africa is a combination of different genotypes and different phylogenetic strains of importance in terms of driving this pandemic. And over the last 7 years or so, we've been able to study historical isolates of Salmonella typhi in Kenya. And what we have observed over time is that our strains first acquired multi-drug resistance, including resistance to fluoroquinolones around the year 2004. And then the rate of resistance has been increasing ever since that time. And so also has been the changes in terms of lineages of importance to the East African region. What we found out is that this particular period of time around the year 2003, 2004 coincided with the time when there was introduction of a new haplotype called H58 from Southeast Asia to the East African region. And with it, of course, that brought multi-drug resistance and resistance to the fluoroquinolone drugs of choice for treatment. And again, this has been growing, as you can see in the third bar graph, where we have a steady growth of resistance to fluoroquinolones. And equally important, of course, is the growth in numbers and in proportions of multi-drug resistant strains. We try to be able to check whether there was seasonality associated with increased transmission. And yes, of course, we find some peaks. You find some peaks with regard to peaks in the rainfall months, especially in August, September, in March, April, and May, quite a number of peaks that coincide with heavy rainfall. Obviously, with heavy rainfall, we have some localized flooding, and that then increases transmission in communities. We have also observed over time that there has been an increase in the number of controls or the number of apparently healthy individuals that carry this same strain, H58, that causes severe disease in vulnerable populations. In other words, we almost have an equal proportion of carriage of disease in any one given population in these endemic areas. In terms of age groups, again, before 2004, our historical data shows clearly that the most vulnerable groups for typhoid fever were school-going children above the age of 8 and young adults, mainly due to the fact that, of course, there's a lot of street foods available for school-going children and so forth. When we look at the more recent data, we're finding much younger population now suffering from typhoid fever. And this is, again, very, very disturbing because this is not something we observed before. So we're finding a younger age group now with more typhoid, and it's the same age group that also suffers a huge proportion of non-typhoid Salmonella bacteria. So as we introduce vaccines, we have advised the Ministry of Health to think basically about how we can incorporate all these vaccine, the vaccine introductions and interventions into the API program so that it caters for children below 5 years of age and maybe moving on up to 10 years of age into a very routine immunization program, because this is an endemic disease, again, very, very, in mirror, very, very similar to what NTS is happening. just at looking at the historical aspects of this disease, as I mentioned, we started observing changes of new introduction of new strains of typhoid around 2003, 2004. As you can see in the red bar, that is the H58 strain types, highly multi-drug resistant and resistant also to fluoroquinolones. And more recently, we're finding about 15 to 20% of these strains being resistant to third generation cephalosporins. And this again keeps growing over time and replacing the fully susceptible strains of Salmonella typhi. That's a historical aspect of it, coming from Southeast Asia. So arising from my interest on typhi, in the last 2 years, working with John Gunn from Ohio State University here and colleagues back in Kenya, we got a grant from NIH to be able to look at the epidemiology and genomics of multi-drug resistant Salmonella typhi, and especially being able to particularly look at the role of carriage in humans in endemic settings. And this was mainly a build-up of the previous studies, where we were able to observe huge proportions of apparently healthy individuals carrying the H58 serotype, the H58 haplotype of Salmonella typhi. And basically, we have 3 main objectives, or specific objectives, that is, we want to identify acute and chronic typhi patients in this specific population, and how do they associate with carriage of gallstones. And we want to determine the phenotypes and genotypes of isolates and look at their phylogenetic relatedness in the community. How do they relate in terms of the different population structure, in terms of age groups, in terms of their vulnerabilities, in terms of whether they are inpatients or outpatients, and the environment, how do they relate to the environment in which they live. We want to establish, especially, the relationship between the carrier state and the acute infections to biofilm formation, as we'll be able to measure this using the gallbladder simulating conditions. And this is one of the projects we're working very closely with my colleague, Dr. John Dunn. And we are now into the 2nd year. We've been hugely interrupted by the COVID-19 pandemic, but we hope to be able to make some progress as we understand what the carriage dynamics of this disease is in endemic areas in Kenya. The other area that I wish to sort of end up with, and which is part and parcel of what we've been doing in the last 3 years, is in the implementation of the National Action Plan on reduction and control of antimicrobial resistance. And this is a project that basically was building capacity for improved AMR surveillance, and is funded by the Fleming Fund, which is part of the major funding by the Department of Health in the United Kingdom government. And the key objectives of this program has been to strengthen One Health governance structure, to be able to understand resistance surveillance, but also antimicrobial use and antimicrobial surveillance itself. And what we want to do is be able to strengthen this across the whole spectrum of both human health sector, but also the animal health sector. And to be able to do this, we want to build capacity for those stakeholders that are involved in the various spheres of influence, in as far as public health is concerned, and also animal health or livestock health is concerned. And these are the basic principles that we've been using in the last 2 years as we come towards the tail end of the project. We want to understand One Health and be able to bring the importance of One Health to stakeholders involved in improving public health or improving animal health. And obviously, we know this is a very, very important concept where we want to know how do bacteria spread between different ecosystems. and how can we be able to prevent that spread, and be able to align our funding needs to the broader country initiatives, especially towards the common goal of control and prevention of antimicrobial resistance. This particular program was also geared towards ensuring a sustainable intervention for purposes of AMR control. And so what we want to do is to be able to have a kind of trainer of trainers program in a sustainable spectrum across both public health and animal health ecosystems. And for this, what we've done is to be able to avail resources in terms of equipment, in terms of protocols and training, and in terms of peers that will be able to influence the sustainability of surveillance programs within the hospitals and also within the veterinary laboratories. And along the spectrum, we have involved all stakeholders, right from policymakers at the national level to those that have ownership of this particular program within the areas of influence. And we are working very, very closely with a lot of stakeholders and farmer groups, farmers themselves. This has been very, very important in terms of being able to work particularly with areas that I hope people can be able to hear. Is there somebody?
I apologize.
Yeah, just be sure that
And
we haven't lost anybody.
No, no.
Okay.
Oh, do you want to?
So for purposes of being able to really bring to the fore the important areas of capacity building for purpose of improved surveillance, we've been able to do what we call point prevalence studies in 4 healthcare facilities as a pilot study. And this was to try and understand antimicrobial use patterns in healthcare settings. So we have 2 groups of researchers. We have those that are directing public health and those that are directing animal health. At KEMRI, we have taken leadership in trying to improve surveillance for public health or healthcare facilities. When you look at what antibiotics are prescribed in some of the hospitals, it's a whole scenario of commonly used antibiotics, but also reserved drugs. If you look at self-reaction, before we did these point prevalence studies, I never knew that clinicians would prescribe self-reaction in such huge proportions for common diseases. But you can see it's one of the commonly used antibiotics in this particular setting. And that again is a recipe for disaster when it comes to antibiotic resistance. Right. Again, these are some of the areas where most of the antibiotics are prescribed and used. Pediatrics is the most common area or the most common group of patients where that generation cephalosporins are prescribed, as you can see, followed by the medical departments, followed by the surgical departments. And what we've been doing in these studies is to try to understand why do clinicians prescribe these very high-end or reserved drugs. Basically, it's because they do not have access to laboratory diagnostic services. So they tend to utilize or use very broad spectrum antibiotics to be able to cover for any infection that could be the issue with regard to patients. And what we have done now is to try and be able to develop capacity in those laboratories and for ensuring that clinicians are able now to refer patients to the laboratories for diagnostics, but also for sensitivity testing of organisms that they isolate. And this has gone on very well. And I would say there is now a very huge buy-in by clinicians in the hospitals that we have been able to work with in the last 2 years for them to be able to adopt laboratories as part and parcel of their healthcare system. So one of the conclusions from these point prevalence studies was that there is high prevalence of antibiotic use, and this cuts across the board, but particularly of importance is the extended spectrum of beta-lactams. A lot of drugs that are broad spectrum are also used across the board. Limited use of laboratory data and guidelines at the 3 hospitals that we studied. Clearly, because over time, the labs were not able to deliver the required results for purpose of diagnosis and surveillance. Prophylactic use of antibiotics, that's a major issue with surgical site infections. Again, completely uncalled for use of antibiotics, which leads to resistance. And stewardship was a big area where there's need for improved and sustainable involvement of clinicians for stewardship of antimicrobial use. So in our National Action Plan implementation, which began in the year 2017, we developed national policy, which was involving all stakeholders. And we also developed a national action plan. And now we have a strategy for implementation. And this is what we've been using. And these are the various stages for the implementation. We particularly do assessment of how the various stakeholders are going to be involved. And then there is, of course, the preparation of the various areas for intervention, and then implementation, and then monitoring and evaluation is a major area of concern in terms of sustainability of this project. And some of the areas that we've spent a lot of time is especially raising awareness and understanding of antimicrobial resistance. When you go across the whole spectrum, whether you're in human health or livestock, there is some general awareness about AMR, but then there's no ownership because there's a lot of finger pointing. Well, we know the problem exists, but it's probably a problem of the pharmacy department. They're not availing the right drugs. It's a problem of the labs. It's a problem of a medical ward and so forth. But we've been able to change this mindset so that people own the problem of AMR across the board and becomes an integral part of their routine that they must be able to address AMR. And this is part and parcel of a campaign we've been doing across the board, trying across different spectra, including school children, including those college-going students, professionals, trying to ensure that they have the right information, they have the right education, and communicate the right messages for purposes of control of the AMR. And this one such forum, this is with farmers, and this happens all the time with other lay public and those that need to understand why is antimicrobial resistance an important aspect of our lives and for us to be able to tackle it during this time. So this is scope. What we've done is that we started off in pilot phases, and now by next year, we'll be doing a total of 22 sites, right from the implementation of all the 5 objectives, at least starting from the low-lying fruits, where we can look at maybe 3 of the 5 objectives on the National Action Plan and be able to assess them over time and know that everyone is on board in terms of being able to address the problem of antimicrobial resistance. So what's happening elsewhere? And we do this all the time. We really want to sort of measure ourselves with everybody else. We want to go across the board. How is everybody else doing? We've been able to look at what other regions are doing, and we want to understand really what are the challenges they're facing. Can we be able to benchmark with them in terms of improving our monitoring, evaluation, and implementation tools and so forth? And for that, what we've done is to be able to look at certain areas that are of importance and which have been evaluated in Europe, for example, and the world. And we're looking at, for example, what are the mechanisms for sustainability of these projects? How can we sustain the momentum of people who have started surveillance at a public health level institute and be able to sustain it over time without necessarily going to the central government for funding all the time? Can they have a laboratory system that is able to charge a small fee and then utilize that income for purposes of sustaining the supplies and the systems in place for testing, data analysis, and data dissemination to those that are in need of AMR data in that region? And we've learned a lot from being able to look at issues of accountability, equity, engaging all key sectors, being able to understand and make policy makers understand what are the economics behind AMR. What's AMR cost? What's the cost of AMR as far as the population is concerned? What's the cost of AMR as far as livestock is concerned, and so forth? And this is very important because policymakers only understand dollars and shillings. If you tell them that this year alone, if we don't tackle AMR, we're going to lose so many people in this sector, we're going to lose so much money in this sector, then they will be able to listen. So we must be able to have that data ready for purposes of sharing with stakeholders. Again, we've learned lessons from others who have been involved in this implementation of the National Action Plan regarding regulations, regarding focus on data, especially being able to produce data that can be used at the local level. That's so crucial. Data for the sake of data and surveillance is not going to work in most of our countries because people want to know, why are you collecting this data? Is it applicable to us? Is it something that we can use to improve our public health? And this is very, very important. And these are some of the lessons that we're finding that are useful, even benchmarking with our colleagues from elsewhere. So closer home, we have also been able to benchmark with Ghana, and some of the policy recommendations in Ghana and Thailand have involved, again, patient-centered approaches. We'll be looking at patients and training patients on why should they, for example, use only recognized prescribers of antibiotics. Why is it important to complete the full prescription? And we found this very, very important when we used school children as a way of educating their parents back home and their siblings back home by influencing their understanding of why antibiotics are important and why we must finish our dose and why we should only take antibiotics that have been prescribed by a medically qualified healthcare person. Policymakers, again, being able to understand, even from benchmarking with our colleagues, that it's so important to have a buy-in right at the beginning with policymakers, with prescribers. Because if you don't have a buy-in, then you'll be doing a project for the sake of collecting data, but it will not be sustainable over time. So these have been very, very important lessons for us to learn over time. And overall, of course, the theory of change is that we want to have these outputs that we are aiming at, and especially looking at the 5 major objectives of the National Action Plan. Being able to utilize these outputs and being able to translate this to long-term outcomes and impact over time. And eventually being able to have a sustainable system of being able to collect quality-controlled antimicrobial resistance data and use that data for purposes of informing treatment and also tracking the spread of disease and AMR itself, and being able to intervene at various stages within that spectrum so that we are able to prevent and control AMR. And this has been a major goal in the Fleming Fund, that at the end of the day, we want to empower stakeholders so that they own the problem of AMR, and beyond the life of this project, that they're able to sustain this for purposes of patient care or animal care for that purpose. So as I end, I just want to sort of spend a few minutes just to look at some of the gaps that we've been able to identify and which are crucially important going forward. We still need to ask ourselves whether we have representative data on AMR, and especially for healthcare associated infections. These are areas where we have very high concentrations of drug-resistant bacteria, very sick patients, and very vulnerable populations. And yet, these are areas where they form a very important result for both genes and mobile genetic elements. We need to have a case for economic cost of AMR across the board, both in livestock or animal health, and also in human health. Because with this, we are able to convince those that are stakeholders, especially policymakers, of why they must intervene in AMR. Antimicrobial use data, again, another important gap that we must address in our region. We must be able to know how much comes through in terms of importation, in terms of prescribing, in terms of other usage that is aside of prescribers. And all this we'll be able to address because we know, for example, misuse of antibiotics gives rise to resistance. But how much is used in public health settings, how much is used in animal health settings, and how much is used in the hospital vis-a-vis the general public. Stewardship is one of the areas that we have put a lot of effort in. We have now a national effort, we have a national program, and we now have a strategy for training on stewardship. Right across the board, right from those that are college-going students to healthcare workers, we have programs for stewardship. But these need to be, of course, stepped up and scaled up to many, many other areas in the country. Infection prevention and control is such an important step in being able to intervene in this and to stem antimicrobial resistance. Yet, we have not had adequate advocacy for purposes of scaling this nationally. A lot of facilities have committees for IPC, but these then need to be scaled up so that we have this as a major intervention to prevent and control antimicrobial resistance. The reason being, of course, we know that from other studies elsewhere that IPC alone can be able to bring down or reduce AMR by up to 40 to 50%. And that is an important intervention strategy. Buy-in by government, again, an important area that we really don't have enough buy-in by government. I know we have Ministry of Health on board, we have other stakeholders on board, but we must do more to involve many more of them, because it's up to the government in our own countries to be able to sustain the fight on AMR. Without that ownership, then any other intervention will be only short term. We have done very little on environmental aspects of AMR, and this must be really addressed because for us to be able to fully embrace One Health approach in AMR control, environmental AMR must be in the forefront. Those are some of the gaps that we should address going forward in our programs. And these are some of the areas that we thought that could be important as we come through towards the tail end of the building capacity program for the Fleming Fund. Being able to develop an AMR patient pathway. In other words, being patient-centered in our approaches towards controlling AMR, so that at the end of the day, we want to improve the life and, of course, the health of the patient. By doing that, then we are able to put all our efforts towards addressing AMR and that would otherwise compromise our patient healthcare. Also considering a comprehensive programmatic approach across the board, being able to have a graded AMR assessment tool. We want to be able to, of course, train those that are involved in doing assessment, but also have a uniform tool across the board so that we know where are we. If I go to one rural area, if I go to another setting in public health, we know that we're using the same tool to measure implementation and control of AMR and be able to know where we are in the scale on tackling AMR. That, of course, calls for having a kind of essential package of intervention. And this should be fairly simple intervention tools that can easily be adapted by various different stakeholders, different levels of complexity across the board, and be able to strengthen, especially implementation using very simplified guidance tools, things that have been negotiated at that very simple level, be it the primary healthcare level, be it at the referral hospital level, a list of tools, a kit, let me call it a technical toolkit, which can be applied very, very easily across the board. And being able to partner with stakeholders locally and internationally, again, to prioritize the minimum essential packages that can be used for purposes of intervention. And finally, of course, being able to link our response to AMR to existing plans. For example, we have very well developed programs for control of malaria, for control of HIV, and now recently, of course, for control and prevention of COVID-19. Can we be able to link those programs to AMR? Because we are using the same resources, we're using the same tools, and using the same people to be able to intervene at all different levels. And in all these enteric infections, especially with regard to antimicrobial resistant pathogens, we think deploying vaccines will have a short-term to medium-term effect in control of both the disease, but also on AMR. Improving WASH, again, will have definitely a long-term effect by changing the environment in which we are able to supply clean drinking water and be able to have safe disposal of sewage and being able to improve on livelihoods of people. And this again calls for behavior change across the board. And we see that work very well with farmers. You go to a farmer and you persuade the farmers to improve their biosecurity and improve general hygiene on the farm. And they find that the few of their chicken are dying and they're able to get better outcomes from their farming simply because of simple tools of intervention. And when this this is work that has been possible due to collaborations with various stakeholders and with funding from Wellcome Trust and the NIH, and with colleagues from different areas for influence. And I really wish to thank our collaborators and those that have worked very, very closely with us in various areas of, especially the Fleming Fund consortium. So I went there and then maybe welcome discussion, any points of clarification. Thank you very much.
Wonderful. Thank you so much, Dr. Kariuki, for a wonderful presentation. We can now go ahead and take questions. And if you have questions, you can enter them in the Q&A box. Or if there's any questions in the room.
Yeah.
Yeah. So we'll start with Dr.
Yeah. you very much, Professor Kariuki. That was a wonderful oversight of what your institution is doing. And I just want to say congratulations and thanks very much for sharing your wisdom with us and with our team member. One point that I want to make is this growing, the focus that you told us, KEMRI has now the research program in One Health, which is very impressive. And as you know, there are also other institutions in Eastern Africa, including the Arbor Cancer Research Institute. It has now also one of the 6 or 7 directorates. One Health is one of their major directors. We received an invitation from, one of the largest, oldest university in Ethiopia, Addis University, that they plan to open a PhD program in One Health, bringing a lot of people together. And One Health capacity building is happening in Eastern Africa. Couple of points there. One, as one of the lead partners on One Health and globally renowned activity with a number of activity, our office, so I have said Global One Health Initiative, would love to commit and collaborate with this, sustainable kind of strategies as we share a common vision of building capacity. So I want to emphasize on that one. The second piece I want to make is more of a wish than what I think perhaps you may share your idea with us. One Health for most LMICs in general and for Africa in particular is not something new. It has been practiced for centuries and centuries. In the farmers, pastoralists, everyone has been. So my wish is if the new growing and opening institutions and research programs focus on the contemporary one, without giving due attention to the indigenous knowledge that has been there for years and years, I would say that there is a lot of room to learn from there as well.
Exactly.
So it's like a wish and a plea. And if KEMRI is considering towards that, documenting all the history of One Health in that nation, the name might have been completely different, not One Health, but in different aspects. So we seem to miss a lot of historical background and indigenous knowledge moving forward. While acknowledging the opening of different One Health capacity building, I just want to give that remark that we should also focus on the history and beyond. So thank you again. Thank you.
I fully agree. I fully agree with that, Gertnet, and thanks for bringing that up. We've seen even within some of the areas in livestock farming, farmers who utilize what I would say herbal medicines, for example. And those herbal medicines are able to prevent certain diseases.
Yeah.
And with that kind of approach, then they're able to avoid use of the traditional antibiotics for treatment of infections because they have herbal remedies. And again, that is equally important even in public health. Yeah, you find a lot of people in the rural areas who use what they call herbal medicine, herbal products, and they work. Be they skin infections, for example, or probably diarrheal diseases. A mother knows very well that their grandfather used to use a certain plant, boil it, and then within a day, the child will no longer have diarrhea. So these are traditional knowledge that we must mine moving forward. And one of the programs that we have, that the Minister of Health particularly has been supporting in the last 5 years is traditional medicines and drug development.
Yeah.
It's one of the major programs in KEMRI. And what that program is doing is to work with traditional healers across the country. So they come to KEMRI, they register with the department, and then they have an MOU regarding the products that they are going to research on, so that there's intellectual property that remains with the traditional healer. It's not taken over by KEMRI. And then they start now doing chemistry analysis and so forth. And once they identify a particular product or a particular molecule of interest, then they can develop that product for that herbalist. And they have, of course, intellectual property issues that they are sorted out. So there's a lot of traditional knowledge that can be passed on to benefit AMR interventions. Because most of the natural products really do not sort of induce resistance, because by their very nature, they are multi-pronged in terms of how they work. So that's a very important area. And One Health and the traditional medicines and drug development, those are key areas that we want to work along the country to see whether we can get alternative ways of intervention for both disease and AMR as well.
So we have a question, a couple questions from John. So first of all, is the AMR problem in Kenya one of the farm or the clinical hospital?
Yes, indeed. It's a good question. One of the areas that we've been trying to understand is the magnitude of AMR in the different settings at the farm level or livestock. And what you find is that most of the resistance, I would say, is within the intensive poultry farming areas or sectors. And that is within the peri-urban areas around the large cities, where farmers would raise large numbers of birds within a very, very small area. And of course, there's compromised health in terms of even spacing of the chickens, compromise in terms of even being able to keep the chickens in a hygienic manner, so forth. And because of that, the farmers tend to use antibiotics all the time to prevent disease, because they're not able to oversee biosafety, biosecurity within those settings because of the high numbers of birds that you keep within a very small place. Second to intensive chicken farming, the other area where a lot of antibiotics are being used is in swine farming or pig farming. Again, for the same reasons. These are peri-urban farmers. There's a huge market within the big cities. Nairobi, for example, is a 5 million population. So there's a big market. So people are trying to produce meats or protein meats within a very, very short time and under very intensive conditions. Again, that calls for compromised safety, biosecurity, and that, again, as a shortcut, farmers use a lot of antibiotics. But what we know for sure is that the levels of antimicrobial resistance, and especially MDR, multi-drug resistance, is much higher in the human health sector compared to livestock sector. But that is not to say that the livestock sector is to blame or human sector is to blame. But again, the levels of resistance are commensurate to levels of antibiotic usage in the different sectors. So for example, in the hospitals, in pediatrics, and at the referral hospitals, which are some national and national level, there's a lot of usage of antibiotics. Again, you find very high commensurate levels of resistance. So in terms of being able to track transmission between livestock and humans, again, you find a lot of transmission for those that are close to livestock farming areas. You would sort of have the same resistance types and resistance genes that you find within the farming systems. Those that are working within the healthcare systems, again, you find the same kind of patterns because of the fact that there is interaction within that ecosystem. So in terms of usage, much more in the human health compared to livestock. In terms of the types, I would say the highest level of resistance in livestock, especially in poultry, intensive poultry farming, are tetracyclines, followed closely by penicillins and sulfurs. In human health, As we have seen previously, there is extremely high levels of resistance and multi-drug resistance for that matter in cetrin, which we call cotrimoxazole or trim sulfur combinations. Extremely high levels in other commonly used antibiotics, including, of course, semi-synthetic penicillins and the cephalosporins. Recently, of course, fluoroquinolones due to typhoid, again, a big area. In terms of coverage of INTs, is there indication of how it is carried? Yes, this is shedding, very, very similar to the kind of picture you find in typhoid carriage, extremely similar. You find the shedding. We don't know for how long this shedding happens, and this is the subject of our current study that is funded by German Research Foundation. We're doing this with colleagues from Koch, the Koch Institute in Germany, in Berlin. And Robert Koch Institute is working with us courtesy of the fact that they have developed a model of understanding courage of NTS and courage of E. coli. And this is a colleague that worked with us at the Sanger Institute, and jointly we got this grant from the German Research Foundation. And what we want to understand is how long is this courage happening? Is it as long as, for example, the typhoid courage? Is it related to courage within the gallstones, as we know in typhoid, long-term courage in typhoid? Antibiotic treatment, yes, it's a major indicator, but at the same time, it's difficult to be able to establish whether those that are apparently healthy in the community, and especially home states where we find NTS courage, have previous treatments. What we know is that for sure, in general, in that community, there is a lot of usage of antibiotics all the time for various reasons, for both prophylaxis and for treatment of infection. What we don't know currently is how much of that self-treatment and antibiotic pressure comes to bear on the proportion of courage within the homestead and the community in general. It's one of the things that we're doing currently. What we're doing, just like we're doing for typhoid, is to be able to monitor over time, longitudinally, the shedding of INTs over time, especially for children below 5 years of age and their siblings, those that are apparently healthy, those that have been treated and discharged, do they continue to shed a long time? And this is an area that is of common interest, very similar to what typhoid courage is all about. And we could discuss more with Dr. Gan, maybe for purposes of seeing how we can relate this study to the typhoid courage study.
Wonderful. And just so everyone knows, the question was, you talked about the carriage of INTS. Is there any indicator of how it's being carried or any specific traits of a carrier? And then Dr. Kariuki also answered, is antibiotic treatment of an common indicator of carriage? So thank you for answering those questions, Dr. Kariuki. And we have a question from Joseph. Could you enter your question in the Q&A box? And while Joseph is doing that, I would just ask you, do you ever take samples from urban wildlife to look at transmission as part of the One Health?
That's a very important question. We haven't yet done studies on AMR associated with wildlife yet. I know our colleagues, Dr. Kazuara in Tanzania and others have been doing this kind of work. It's one of the areas that I would welcome a graduate student to be able to undertake, because it's a big gap. And as I mentioned also, the other big gap is regarding the environment as a component of the One Health. Again, that needs to really be comprehensively analyzed in terms of the contribution towards livestock and human in both disease and of course in AMR. And those are some of the gaps that we need to fill.
Questions from Joseph. He asks, could the presence of counterfeit antimicrobials in low middle income countries be driving false negative responses of microbes to the available antimicrobials and be loosely defined as AMR?
Yes, indeed, Dr. Anguta, that's a very, very important issue that you raised. For sure, yes. As you know, we grapple quite a lot with counterfeit antimicrobials that slip through our porous borders into the country. Again, the fact that our systems are not able to monitor effectively those drugs that come across the borders without necessarily being officially registered through the liquid systems. I'll tell you, of course, the Pharmacy and Poisons Board is a very strong arm of surveillance, being able to look at what is available in the market and the efficacy of those kind of antibiotics and antibiotics in general. But then a country.
May I have your attention, please? May I have your attention, please?
I apologize. We have a
Following
fire drill.
test of the fire alarm
Thank you so
system,
much, Dr.
there is
Kariuki,
no
for
need
your
to
wonderful
respond or
presentation.
evacuate.
I think
The
we'll have to
following
conclude.
will be a test of the fire alarm
Thank you so
system.
much,
There
everyone.
is no need to
and
respond
we
or
will see you in
evacuate.
September.